We talk of compound fractures. At the roadside. It is important to stop bleeding, and that is by elevation, pressure, compression bandage, which you must learn to tie, or tourniquet. Four principles of use of tourniquet are: avoid as far as possible, always on a single bone, not too tight, not too loose, and finally 5 minutes release every hour that you have tied it. 60 minutes. So after establishing hemostasis, you must clean the wound or wash it, put antiseptic or antibiotic so that contamination by bacteria doesn't convert to infection. This should be done within 6 hours, which is called as golden period. After the cleaning and washing, you must always cover the wound. Align the bony fragments. Or grossly reduce the skeletal disruption. Assess vascularity, nerves, and life endangering conditions. Manage what can be done, or at least record so that the future people must see. And then you must transport. Two words to transport. First is appropriately. That means to the nearest center where beds are vacant and where all problems of the patient can be managed. This is the definition of appropriately, and with full information. And the most important part of information is your contact number or mobile number. So this is what is done as in roadside. Then in the hospital, you must complete the pre-hospital care, you must classify into walking, talking, breathing, and bleeding, broken, dying. You must put the patient nil orally and prepare for anesthesia, you must assess or evaluate the injury, including imaging. And imaging, most important now, is the whole body CT scan to look for all injuries that could otherwise have been missed. But basically, an X-ray, one joint above, one joint below, that's the extent of the X-ray, and at least two views, AP and lateral. So that will tell you the site of injury, site of fracture, and the nature of fracture. Never forget to assess for vascular insufficiency, or neural deficiency. Then after the patient is fit for anesthesia and surgery, you transport the patient to the OT. In the OT, you cover the wound, you do a aseptic preparation of surrounding skin. You clip the hair. Don't shave them, because shaving creates micro wounds. Don't shave. Then you remove the cover. You enlarge the wound. You trim the edges. You do an appropriate or adequate fasciotomy to break the edema ischemia cycle. And finally, you look at the muscle. You remove the dead muscle. Which is recognized by color change. It's more blue than brown. By bleeding on touch. On cutting is absent. And twitching on touch is absent. You evaluate the wound, find out exactly what is damaged, stitch tendons, repair blood vessels, at least tag the nerves, and then you evaluate for hemostasis and dead space. If there is hemostasis is not adequate and there is a dead space where there will be a collection and infection, you leave the wound open. But if you have to close the wound, if there is no dead space, adequate hemostasis, or there is a surface like tendon or like bone which will not take the granulation, in secondary healing, or the wound is across a joint where secondary healing will cause a contracture. So this is how you decide on closing the wound or not. Now, what are the techniques of closing? Techniques of closing are primary suture, never close the fascia, deep fascia. Secondary closure, or you may have to give release incisions if there is tension, or you may have to do fasciocutaneous or myocutaneous, pedicle graft. One of the important things here is you either stabilize the bone so you reduce and you retain. Now this retention can be temporary or it can be definitive depending on the grade of the wound. So you retain the wound. In the post-operative period, if you have left the wound open, here I have to say that if you have left the wound open, then the best method is that you cover it with plaster, and this is called as Vinet or closed plaster method of treating wounds. Secondly, wash or not wash. Wash or not wash is controversial. So instead of wash, you can shave off the surface which is contaminated. For example, you can remove the fascia. If this is the fascia, and here is the wound, you can remove this fascia. You can remove the surface which appears to you to be contaminated. Post-op, elevation, active movements, moving all joints, not immobilized through their complete range. Watch for general condition, pulse, blood pressure, fat embolism, infection, temperature, intake output. Then you remove stitches, understand something which is called secondary healing? In the secondary healing, if this is the wound, the first thing is that the contents of the wound must drain properly. The second thing is that there is this slough. So slough is removed by hydrogen peroxide or chlorine water dressings or U-salt dressing, Edinburgh University solution dressing. Then you have to promote granulation. So granulation is promoted by decreasing frequency of dressing, using non-adhesive dressing, and sometimes using scarlet red. Supposing there is increased granulation, you deal it with by hypertonic saline, or you deal with it by silver nitrate stick, so you actually burn the granulation by the silver nitrate stick. After that, there is epithelialization. And epithelialization can be promoted by decreased frequency, non-adhesive dressing and scarlet red. And after that, there is keratinization. And this keratinization is managed by or increased by powder dressing. So these stages of healing and how to dress them, you must know. In case keratinization by powder, epithelialization by the same methods. These methods of dressing you must know in case you want to do. You don't want to do the Venetor method and you want to choose open dressing method with external fixator. Then we come to reduction, retention, wound management, and finally we come to rehabilitation. Rehabilitation begins with the injury. It first aims at decreasing the injury. Secondly, it helps in sustaining morale and respiratory complications and sores. It wants to prevent this. Then it moves joints not immobilized through their complete range to prevent stiffness. It maintains muscle tone. And then after the union is sound, it restores joint movement of immobilized joints. It maintains muscle control of joints, and it promotes gradual weight bearing. Finally, rehabilitation also deals with residual disability. So this is how we normally approach a case of open fracture or compound fracture. And one thing which you must also remember is Gustlow grading of wound associated with fracture. Usually the lower grades are inside out wounds. This is the fracture and it has burst from inside out, so the skin defect is small. And outside in are usually very large wounds with flaps. The commonest bone where you have the compound fracture is both bone leg. So you remember these things about a compound fracture.